Hello everyone. Now I'll discuss question of psychiatry. So we have a 74-year-old lady, elderly lady, brought to you by her son. He's concerned because his mother had unprovoked fall a year ago. And since relied on from that time, she's totally dependent on him to coordinate her activities and make decisions about everyday matters also. Patient's symptoms seemed to improve until the sustained another significant fall about 6 months ago. She again became mildly forgetfulness, experienced occasional mood swing, and now seemed sad most of the time. The patient has a long history of hypertension, stress, urinary incontinence, depression. Family history has a positive for colorectal cancer and Alzheimer's disease also. At the moment, afebrile BP is fairly normal. Vitals are normal. Neurological examination shows weakness and sensory deficit on the right side. Mental status examination is significant for low volume of speech and flat affect. Remainder of examination is normal. Neuroimaging would likely to show which of the following. Okay. What we expect in this? Well, cortical or subcortical infarction is what we can expect in this. Well, if you look into this question, this patient presentation is consistent with likely undiagnosed strokes and due to vascular dementia, what we write as VAD. Patient has weakness on the right side. Okay. And moreover, she is having a sudden change in functional status. That is the classical feature whenever we think about vascular dementia. And perfectly all right. Sudden she has an unprovoked fall. And that is characterized by early problem with the executive function like planning activities, making decision, what she suffer only after the fall. And now she's totally dependent on the son for all these activities also. And moreover, the classical feature is stepwise decline. Patient had a problem, stable for some time, again second fall, again deteriorated. This is the so-called stepwise decline. This is the classical and one of the diagnostic feature of vascular dementia. Okay. As I told you, patient was stable, again had a second fall and subsequent problem in the mood, etc. That is again another vascular diagnostic of vascular dementia. Again, she has early mild forgetfulness, which is again a feature of vascular dementia. Well, we can differentiate from more profound memory problems seen in Alzheimer's disease. In Alzheimer's, it's a profound. Patient has serious memory deficit in Alzheimer's disease. Now I have a question for you. In Alzheimer's disease, memory loss is there, that we know, and severe memory loss occur in the late stage. Okay. Now the question is, what is one of the earliest feature of Alzheimer's disease regarding memory? Stop the video, write down the answer. Answer is nominal. Patients tend to forget names. But before I proceed further, just to inform you, forgetting name is a normal physiology also. Especially in the aging process, this can be a normal finding. People tend to forget names, but it is one of the earliest features of Alzheimer's disease also. Okay, what we call as nominal aphasia. Okay, well. Now, moreover, in this patient, patient has there are so many risk factors for stroke like age, she's an elderly lady, hypertension, focal deficit, right-sided hemiparesis, sensory deficit. That means patient already have predisposing factor for the stroke, and already she must have stroke also. That's why she has neurological deficit are there. and they're all consistent with diagnosis of vascular dementia. Now, if you do neuroimaging in this patient, we demonstrate cortical or subcortical infarction with or without deep white matter changes into chronic ischemia. Okay, even white matter problem may be there in such cases. Now let's look into other option. What about frontal and temporal lobe atrophy? This is seen in frontotemporal dementia, what we also call as Pick's disease. Okay, and it present with progressive personality changes such as disinhibition and compulsive behavior early in the disease. This need to be discussed. Why the patient has disinhibition? Well, this is central sulcus. This the whole is the frontal lobe. In the frontal lobe, we have a prefrontal cortex. It is this area which regulates our normal social behavior and personality. And by this, we have to follow the rules of society. If this is gone, if this is damaged, which is typically damaged in the frontotemporal dementia or atrophy, Pick disease, because then social control is not there. The person will start passing urine in public, which is not socially acceptable behavior. He has no inhibition passing urine in front of everyone else. So this is the reason why they have more of a disinhibition or antisocial behavior, to be more precise. Okay. Well, patient had occasional mood swing, but her stepwise. But in our patient, the question, occasional mood swing and stepwise decline are more favor about vascular dementia. Now, one more thing I like to add regarding in Pick's disease, temporal lobe may also be involved. Temporal lobe is the area where memory is there, but it's a usually later feature. That's why antisocial behavior is the first finding and memory deficit is the late finding in frontotemporal dementia or Pick disease. Well, the option C is medial temporal lobe atrophy. This is the classical finding that we get in Alzheimer's disease. And we know it's a slowly progressive neurodegenerative disease which can lead to dementia, that is loss of memory. In fact, it is the most common cause of irreversible dementia. Okay. Well, again, I have a question. Stop the video, write down the answer. Tell me certain reversible causes of dementia. Write down the answer in your copy. So some of the important reversible causes of dementia are vitamin D, B12 deficiency, hypothyroid, subdural hematoma, HIV, etc. are some of the important causes of reversible types causes of dementia. Well, as far as Alzheimer's disease is concerned, memory loss followed by problem with language and visuospatial deficit is the classical finding. Again, when we are getting this word, visuospatial deficit, most likely you are dealing with Alzheimer's disease, antisocial behavior, you are dealing with frontotemporal dementia and stepwise decline, that is vascular dementia. So our patient presentation is more of consistent with vascular dementia because the abrupt and stepwise decline, focal deficit and mild memory loss, they're all feature of vascular dementia. Well, no abnormality. Major depression may be accompanied by or present with the cognitive impairment in the elderly person. It's not typically associated with any neuroimaging abnormalities. Definitely, we don't get any abnormality in depression. Despite her history of depression, the patient prominent neurological dysfunction, unprovoked fall, focal deficit, that is, there is a right hemiplegia or hemiparesis. sensory loss also. Disease course is more consistent with vascular dementia than the depression-related cognitive impairment. Ventriculomegaly, that means enlarged ventricles. This is classically seen in normal pressure hydrocephalus. Okay, and it is now in there's a classical triad of normal pressure hydrocephalus, ataxia, dementia, urinary incontinence. Okay, well, before I proceed further, we have a ataxia, which is usually followed by ataxia usually occur first. Now, what type of gait we have in this patient? Stop the video, write down the answer in your copy. Well, they have a magnetic gait. Okay. Now, in our patient, again, more problem of looks of a VAD we already discussed, because our patient doesn't have these problem. The normal pressure hydrocephalus is ruled out. Okay. So golden line to remember: vascular dementia typically come as sudden or stepwise decline in executive function. Remember, other option what we discussed, they don't come with sudden, and they don't have stepwise decline. Patient can have focal deficit on examination, and neuroimaging will show cerebral infarction or deep white matter changes can be there in from a chronic ischemia. Thank you very much.